fourth session, which is titled Health Economics Research, but I will tell you that I charged the two people that are kicking off our deliberations to think about health economics, but also to think about what would be the way in which a study could be designed that would lead to a robust systems and policy change, because that's the ultimate goal. We don't want to conduct a study just for the purpose of conducting a study and publishing some really lovely peer-reviewed papers. We want to really leverage this moment as an opportunity to change the systems within which the research takes place, but also to generate the type of evidence, as I said earlier, that would change hearts and change minds and change policies and change pocketbooks, so that this could be something that could be taken to scale in other places. So we are fortunate to have Bruce Schackman and David Paltiel, so I'll turn it over to you all.
Super, thank you. Very grateful to be here and very thankful for the opportunity, and also want to congratulate NIDA for getting out ahead of the curve. We're accustomed to being included as an afterthought rather than being included alongside the design of a trial.
Usually we're at 4:30.
Yeah, that's right. So it's very gratifying, very refreshing, and we're very grateful. I think it's particularly appropriate given how many of the comments so far today have pertained to the idea that this is really a study of service delivery, and to the extent that that is the scope of the study, questions of feasibility, scalability, generalizability, sustainability, affordability, any ability you want, and whether it's worth it seems central to the questions at hand. So with that, let me just move to the very first. I think that most of you, when you think of the economic considerations, think very specifically about a basic exercise in cost accounting. And for those of us who conduct economic evaluation alongside clinical trials and for health and medicine, there's a much broader progression of questions to be addressed. And each one of them, I think, is important if we're going to inform system change and policy impact. Certainly, we begin at the base with cost assessment and asking, what does it cost to deliver a unit of service? What are the costs of treating an adverse event? What are the key components and drivers of cost? But if we're going to think about scalability, if we're going to think about implementation and feasibility, we need to move beyond that basic cost accounting exercise and start drawing things that an economist would refer to as a production function. To ask the question, how expensive is it to scale this intervention up? Are there fixed costs that must be incurred before any units of service can be delivered? Is there a point at which one achieves what you might call diminishing marginal returns to increased investment? In other words, is there a point at which additional dollars are simply having little or no impact on how many units of service are delivered? We're going to want to think about sketching that whole production curve. It usually has a sort of logistic or S-shaped function. You got to invest the money before you get anything, then you get returns, and then finally you max out. We also, if we're thinking about combinations, and I know that we in the prevention business especially like to say that, there's no magic bullet, that there's going to have to be a combination of interventions, then we're going to have to think about what these combinations cost and how they interact with one another. We like to say that, the sum is more, the whole is more than the sum of the parts. But in fact, many of the interventions that we think about, and certainly Bruce and I come out of the world of HIV, where programs can be not so much synergistic, they can actually be antagonistic and undermine one another. So we're going to have to think about which interventions complement which interventions and draw production functions not only for individual interventions, but for entire packages or bundles or portfolios of intervention. Moving beyond simple cost analysis, we want to know, is it affordable? Is a given intervention affordable? Who are the winners? Who are the losers from among the various stakeholders involved? And then ultimately moving to questions that are of particular interest to me, and that is, what is the return on the investment? Is it worth it in some comparative sense if we have a limited budget to allocate across competing interventions? What is or is not cost effective compared to the alternatives available to us? So there's that whole spectrum of questions that extend far beyond simple cost accounting that I think are essential to think about if we're going to inform system change and policy impact.
So I just wanted to kind of bring this to this audience with some examples. This is based on work that we've done in our center as well as other work in the field on overdose prevention, and talk about these different levels. So in terms of looking at the cost, what David called the accounting cost, we look at understanding that naloxone distribution, if that's one of our interventions for overdose prevention, can occur in different sectors. It can be community-based distribution, it can be pharmacy-based distribution, it can be first responder distribution. Each of those has its own cost elements. And then each of those different distribution programs may have a different impact in different communities on the probability of actually preventing an overdose, and trying to calculate that based on existing overdose statistics and the likelihood that the overdose is actually witnessed, that it's not occurring alone, that the person who's witnessing the overdose actually has naloxone, and then the person actually uses that naloxone. And then if overdoses are prevented, what are the costs that are avoided? And this might be more relevant for things like supervised injection facilities, but are you avoiding the cost of a transport to the hospital? Are you avoiding the cost of a hospitalization or an ED visit? And then these other costs that we've talked about, or these other impacts that we've talked about that have cost implications, which have to do with HCV and HIV transmission, but also, importantly, skin and soft tissue infections. So part of overdose prevention is also teaching people who are going to be actively using how to use safely, not only with clean needles, but also in septic ways that prevent these very costly and infectious diseases that can lead to long hospitalizations. And then, as David talked about the production functions, so that really thinks about, okay, how are we going to deliver that naloxone? Are we going to deliver it in a group setting, which has one cost associated with it? Are we going to do it one-on-one? Are we going to do it in a broad community, as we talked about the opportunity when we're doing community prevention to also do naloxone distribution? But that has a different impact than one-on-one, which probably is more expensive, but you may be more likely to getting the naloxone in the hands of someone who's actually going to observe and intervene with an overdose. So there's an efficiency of that production function, if you will, in terms of what the returns are. We often think about, in this case, using geospatial analysis to identify hotspots, and therefore is the distribution program being responsive to the new hotspots as they occur? Is it nimble, or is it slower because it's not so tied into surveillance efforts? And that all leads into the return on investment, so to speak, or the bang for the buck. You may be spending a lesser amount, but having less impact on overdoses. Looking at the portfolio, we think about, well, how much money should be going into this community-based distribution versus pharmacy distribution versus putting naloxone in the hands of first responders. One of the things that we're thinking about with support from Carlos Blanco and others tonight is looking at the impact of naloxone going OTC, and if there's over-the-counter naloxone, is that going to improve availability in the pharmacy because you're going to have it on the shelves, and there's going to be fewer barriers to going up to the pharmacist to fulfill a prescription. But depending on the price also that over-the-counter naloxone is available, whether it will be covered by insurance or not. In terms of budget impact, it's important to think about the fact that there are, as we call them, winners and losers within a budget framework, and that has really implications in terms of sustainability. So the entity that may be saving money, say by fewer hospitalizations or fewer transports, may not be the entity that's necessarily paying for some of the interventions. And trying to align incentives accordingly, which is sort of the next step of designing payment systems, really is trying to address, in some cases, the fact that an investment has to be made and it's going to take longer than a year to get a return on that investment. But also, even within a short-term budget period, there may be savings that are not realized by the entity that's making the investment. So we look at program costs from the health department point of view, At the state level, there may be different buckets within a state. The Medicaid, and this is why I think having the governors involved is really important, because the Medicaid budget may have a different impact than the mental health and substance use budget, and often there needs to be a significant investment in surveillance and strengthening surveillance systems, and that's always viewed as a cost center, whereas in fact having those surveillance systems in place may be critical to the efficacy of your program. And then at the federal level, we have Medicaid and Medicare and CMS, and sometimes those are even separate buckets, is all I'm going to say. And then from a cost effectiveness or return on investment point of view, we're looking at overall costs avoided and incurred. And in some cases, you have to make an investment in the health system in order to get a return down the road. We don't question that outside of substance use necessarily. And then finally, we think about the societal costs, which is important to those who are actually the taxpayers, including criminal justice and the value of life saved. In my next slide is really to talk about the importance of administrative data, which I mentioned earlier in a question. So on the left is just an example of a study that was done through our group at Boston Medical Center using commercial insurance claims data. And you see the very disappointing retention and care for buprenorphine and naltrexone. And this is similar to some of the other data that was shown, but this is commercial claims data. It should be pointed out that even though Medicaid is a very important focus for disadvantaged populations, the majority of patients with opioid use disorder actually are covered by commercial insurance, including, importantly, the children and dependents, young adults who are dependents or are still on their parents' commercial insurance policies. And so you can use insurance claims data to monitor some of these outcomes. But ideally, what you want to do is link that insurance claims data to a whole suite, if you will, of other data that's available. And in Massachusetts is one of the first states that has created this initiative called the Chapter 55 data set. And I'm not expecting you to look at the schematic and really understand it, but just note all those different colors where it says data sources on the left of that slide, and you can see that they've integrated against what they call a spine or a backbone of health insurance claims data in the state, data from public health, from Medicaid, mental health, public safety, jails and prisons, data on homelessness, and then aggregate data on characteristics of the different cities and towns. So creating these integrated data sets is another way to look at health economic outcomes and also other of the structural and other outcomes that we talked about earlier.
Now, with Radana's permission, a few lessons from our work in HIV, and keying off of this morning's discussion on study design, many of the most pressing uncertainties in opioid use disorder policy are not going to be addressable via the traditional forms of clinical investigation. Randomized clinical trials and observational studies are the gold standard. They are the best way of doing things, but in many instances, the time horizons are so long, the outcomes of interest are so rare, the population settings are so diverse, the logistical obstacles and the ethical constraints are so onerous that it's simply not possible to mount the kinds of trials and investigations using those methods. And when those real-life circumstances conspire against those better methods, modeling is going to serve as a practical means of assembling the existing database, conducting formal assessments, and generating entirely new information that could not be obtained by other means. It can also be conducted as an adjunct to clinical or implementation studies. But I think that, everything that I heard this morning's discussion or this afternoon's discussion suggests to me that the noise is inevitable. We have to prepare for the noise. We have to prepare for the fact that we will not be able to design the perfect trial, and that ultimately we are going to have to assemble the data and generate information using model-based approaches. And just to illustrate a couple of ways in which we have used these methodologies in the past successfully to inform decisions that are very similar in their structure to the ones that we're presented with here today. Just two very quick examples.
So this is just a schematic, and again, I don't expect you to read the entire schematic, but this ROM was just funded by NIDA. My colleague Benjamin Linus at Boston Medical Center is the principal investigator and part of our center, one of our core leaders. So what the idea is that to think about over time intervening at different points in opioid use dependence to respond to overdoses. In the box in the middle represents people who are out of treatment, and then there's different ways that people can be in treatment. They can be in treatment with naloxone therapy, with buprenorphine therapy, and with methadone. Those are the sort of three going down the right side, but they can also be absent because they're in a correctional facility. They can be going through detox, or they can be in a residential facility. And one of the important things to think about is what's the risk of overdose in each of those settings, and whereas you might think that the risk of overdose is highest with no treatment, in fact, there's a very high risk of overdose in exiting from detox, as we talked about. There's a very high risk of overdose in exiting from corrections unless you can link people directly into treatment. And so using data from these integrated data sets, in part from the Massachusetts data set, we're able to, we plan to model those transitions based on data that exist, and then we can look at the effectiveness and cost effectiveness of different interventions along all of those different arrows.
One more example. Oh, you can't see the website. So if you're interested, I can give you the web address later. But this is a NIDA-funded piece of work. Shout out to you, Peter Hartsock, thank you, that I'm conducting with my colleagues Greg Gonsalves and Forrest Crawford, reconstructing the Scott County HIV outbreak. And I pointed out to you here because it was a means of taking publicly available data on incidence and recency assays to more or less prove that what Dr. Volkov said in her blog about the avoidability and preventability of that outbreak was entirely correct. And you can actually go to this website. It's available, up and running now. The paper will be coming out shortly. But the web application actually permits you to turn back the clock and to modify the model parameters, but also to experiment with the alternative timing and intensity of interventions to see what could have been in Scott County. It's not only an exercise in Monday morning quarterbacking, however, it also offers a forward-looking assessment as to preemptive approaches in other settings as well. And I think it's a perfect illustration of the use of modeling approaches as a complement to the more traditional forms of clinical investigation. And I do apologize that the web address isn't legible, but I'm happy to hand it out. Let me just close with one last thing. We are not only setting priorities here for a particular set of interventions, we're also setting new research priorities. The number of important questions and worthy studies greatly exceeds the funds available to pay for those studies. And I just want to put in a plug for something called value of information analysis, which is a well-established methodology that is commonly used in other domains, both in the public and private sectors, but is not commonly seen in the NIH research agenda. It's a methodology that asks the question, what's the best decision I can make today, using my current available data? What are the costs, benefits, and risks of that decision? And how do they compare to the best possible decision I could make if I held the decision hostage in order to gain better information, recognizing that the decision to hold a decision in abeyance is itself a decision that carries costs and consequences. And we have done work in this area with the AIDS clinical trials group to help them inform their priority setting with regard to the new research agenda. And I strongly urge NIDA to also think about using value of information methods in its priority setting for new research. And with that.
And I'm pleased to say that David and I were both collaborators on that paper. That's it.
Okay, thank you. So I think now we are going to have we are very fortunate at NIDA to have one of the very few health economists at the NIH, in Sarah Duffy, and she's here with us today, and she's going to kick off our discussion around the health economics and policy questions.
That one, thank you. So thank you very much, Donna, and thanks you guys for a wonderful presentation. I just wanted to sort of restate NIH's interest in health economics research, which was clarified in a notice a couple of years ago. NIH is interested in health economics research in which health outcomes and health-related behaviors are the primary focus, and the connection between the subjects of the study and improved understanding of health are clear and explicit. And so I think economics research, alongside the types of interventions and combination of interventions we're doing, whatever they are, will be very valuable and also fit within the mission. And I liked the way that David and Bruce sort of talked about the different types of economic analysis that go into sort of what we ultimately think of at NIH oftentimes as being economics, which is kind of cost effectiveness analysis or cost utility analysis. I wanted to just point out that we had talked about quality of life before, and one of the outcomes that an economic analysis can assess and use is, in fact, measures of quality of life, usually based on functioning and that kind of thing. And Bruce has actually done a lot, and colleagues have done a lot of work on what that would be for individuals with opioid use disorder. And I think in this case, again, we're going to have multiple different things going on, we think. Modeling is going to be key for this, both, I think, to evaluate the interventions, but importantly, I think also to help perhaps guide what happens. If we were to go, say, in a communities that care or other kind of community based process, I think having economics along the whole continuum will be very important. So at the beginning, trying to help communities understand what the cost, what is the economic burden of disease in your particular community. One of the things I hear, at least in news reports, is one of the real costs of this whole epidemic, besides the horrible deaths and all that, is they can't find people to fill jobs. So bringing in, again, you talked about business leaders, bringing those people in, and perhaps even using sort of economics as an intervention. Are there interventions that help people not only overcome their opioid use, but also be able to hold on to a job? And we normally think of it as an outcome, but maybe that needs to be an intervention. When we think about the supply side, one of the things that we might consider, again, is economics as an intervention. One of the things Virginia just did was increase their payment rates for Medicaid. And it seems to be having an effect in terms of increasing the supply of physicians who are willing to provide this type of care. I think another way economics can perhaps help, if we don't certainly go into the sort of randomized controlled trial type of design, there's certainly econometric methods using, and they're being advanced all the time, sort of advances in synthetic control methods or IV methods or regression discontinuity designs that may be helpful if we decide that randomization is not the way to go. Let's see. The other thing I just wanted to toss out, it's not really economics, except that sometimes you go do this to get the economic data you need, but qualitative analysis. So one of the things we're a little concerned about, I've heard some people, different people are worried about different things, but suppose you do these interventions and then you find they don't work. One of the things that can really help is to understand, talk to people on the ground. Well, why did this not work? We had a study that looked at quality improvement and tried to incentivize that, and it didn't change anything. And they went on the ground. Well, because we don't have the resources. So really understanding on the ground what the impediments are, I think, can be another way to do that. So thank you.
Okay, great. Thank you, Sarah. Do other people have questions and comments with regard to the economics section? I'll start with Chris and move around. John, can you rotate your tent card for me? And then I'll get to you. I'm going to start with Chris, and then I'll go around.
I agree with Sarah. I think that having an economic view throughout the process will be really important. I have worked for well-known economists in my time in ASPE and have supervised many well-known economists. They always bring a different view, and econometric methods are different than sort of the traditional epidemiological methods I'm trained in. And I feel like we always come out with a better product. It introduces debate. I find economists to be completely lacking in emotion, which is good. That's a broad generalization. Right. But when it comes to looking at the effectiveness of something, they just sort of detach from it. And it's like, here's what it says. Whereas others, such as myself, tend to get a little emotionally engaged. So I think it's a really smart piece to not only just say, well, what's the cost effectiveness of this, but to really incorporate the methods that economists bring to the table. I think is really good. I'm just curious on sort of the modeling side, as you've heard from the various discussions today. What are your thoughts on how you put all of that together? So obviously there's systems level issues in the HIV space, which you've clearly worked in, but just in the nuance of what's been discussed today, I would be interested in your sort of quick take on that.
I'll take a shot. So there are several different types of modeling, flavors of modeling, if you will, that are available. And so it's not a one-size-fits-all. So the state transition model that I put up there, which is particularly going to be useful at looking at some state-level interventions, may not be what is important to look at in terms of particular interventions around risk behavior of injection drug users, where an agent-based modeling might be appropriate. There are other modeling approaches that might be better for looking at operational outcomes, sort of from a process flow point of view. So modeling is a general term, but then adapting the modeling technique that's appropriate to the question being asked is a really important step. And there is guidance out there, and there are standards out there that have been published that we refer to in terms of the selection of the model and also in terms of quality assurance for modeling.
They could do, I actually thought we could do a study here. They could do modeling of the capacity of the treatment system. And I don't think I've ever seen one, but they could do it with existing data, and they could build in quality measures or the extra cost of what it takes to use evidence-based practices, and I think they could do that. That's one I would put near the top.
If you hand a child a hammer, the whole world starts to look like a nail, and that's the difficulty, of course, that we face as modelers. And so we do, as Bruce said, try to adapt the model to the question at hand. Just to give you one more illustration, the idea of hotspots has come up quite a lot here today, and I've been thinking about the fact that we do have some very nice analytic models, many of which actually came out of the Second World War search for U-boats on the North Atlantic, having to do with the optimal ways of search and Bayesian approaches and adaptive search methodologies, and I've been just toying around during the spare moments here on those sorts of frameworks as well. So it really is a question of adapting the toolkit that we've acquired, not only as health economists, but as operations researchers to the questions at hand.
Thank you. John?
So I wanted to just relate a brief story that addresses both some of the economic issues at a more microeconomic level and some of the adoption of new interventions that we talked about earlier and that Tom spoke about. NIDA's first clinical trials network study was a head-to-head comparison of buprenorphine to clonidine for detox. And there was an inpatient one and an outpatient study. One of the sites that participated in it was Phoenix House, and Terry Horton was the director of Phoenix House at that point. And after they ran their first 15 patients in the study, buprenorphine had been so remarkably more successful than clonidine that they dropped out of the study and adopted buprenorphine. And the reason that they did it was because their dropout rate in a therapeutic community during the initial detox period was so severe that they were losing patients all of the time. And that had an economic impact on Phoenix House. And many of these programs, particularly addiction specialty programs, are squeezed for budget. And so these are important. So one of the things that we should consider in planning this is, are there going to be any economic benefits for programs that might be struggling to do that? At another end, even large hospital systems like the NYU Health System and Mass General have been adopting and developing these consultation teams. And one of the reasons that they're doing it is to help patients, but another reason that they're doing it is because there are economic benefits for them, reduction in 30-day readmissions and so on, that have very significant impacts in terms of their reimbursement.
Thank you. Nora?
And my question, and I think that, I cannot not make the associations, and I've been discussing about the ability to do modeling to understand the economic components of our interventions to make decisions when there are limited resources and funding, and at the same time, the presentation that David was saying in terms of what is the most effective intervention that we can do for the crisis, of course, is prevention, no matter where we are. And then that in my brain is associated with data from Dayton that actually shows that there are two Americans, the American with education and the American without education, and the mortality rate of the Americans without education is abysmal, whereas that with those that have education have much, much better outcomes across a wide variety of characteristics, including deaths from overdoses, including suicide, including cirrhosis. So as we discuss these issues and we speak about the notion of a prevention effort and solidifying the capacity of a community to develop the resilience, it strikes that a fundamental component of it is what is the economical infrastructure, which in other ways is translated by what is the education of that population. And it's not something that we've discussed, yet it's very fundamental for addressing the whole concept of the crisis, the opioid crisis, or the substance use disorder crisis. So what are your thinkings in this space? Is this something that is off limits in this type of discussion, or is it something that we need to bring to the table?
You've moved beyond my area of expertise in economics into more macro kinds of areas, but I think you're absolutely right, and it would be absolutely essential for people to understand some of the larger pictures that a real macroeconomist would bring to the table here, saying, there are issues of supply and demand and price, and to the extent that you intervene either with interdiction or with care, you are either raising or lowering the price of risky behavior, and it's having its ripple effects on the rest of the economy and on productivity, and it's having differential effects on people with and without education or greater degrees of education. So that would be a beautiful thing to bring into this discussion as well.
I think a concrete way of thinking about it in the context of what we're talking about here is the idea of productivity that Sarah raised. So this has direct relevance in communities for employers, but it also has a sort of broader impact in terms of people who are employed or are in school, which is another very productive way of spending your time, can have an impact then on the broader community as well. So I think that may be sort of a more tangible way of thinking about measuring the impact of any intervention on employment, productivity among those who are employed, and time in school. I just want to add the other measure that Sarah mentioned and was building on something that Dr. McGovern said earlier is quality of life. So quality of life, in our point of view, quality of life is an economic outcome, just like productivity is an outcome. Our metric of one of our metrics of cost effectiveness is looking at a combination of quality of life and length of life. So you're extending someone's life by them surviving an overdose, but is the months that are, or years that are saved, are those high quality years or not high quality years? And that's something that we add into our models.
I'd like to respond to the question. As many of you may know, in the state of Washington, we have something called the Washington State Institute for Public Policy. And if you don't know about the Washington State Institute for Public Policy, I would really suggest you write that name down and Google it and look at it, because it's created by the equal number of Republican and Democratic legislatures sit on this board, and other people sit on this board. And what they do is cost-benefit analyses of a whole range of preventive and treatment interventions. And the reason I'm talking about this is because if we really want to talk about sustainability of what we do, then policymakers are going to ask the question, what is the benefit of this compared to its cost? And that's why it becomes very important for lead executive, like the mayor of a city or the governor of a state, to be involved because of the wrong pocket problem that often occurs. You do something in prevention in the community, and later on you save money in the criminal justice system. And that wrong pocket problem can be solved when a community is working together, or a state is working together to say, we want to save costs overall. And so what legislators and public officials are doing much more consistently is looking to say, what is the benefit of this and where does the benefit go? And so we're, in all our work on communities of care, we're doing benefit cost analyses at each of the points, because we have more data at each of the points to see what the outcomes are that can be monetized in terms of both benefits as well as recognizing the cost. And one of the things we're seeing with the communities of care program, we've followed people up at age 21. Those findings are just now out in the American Journal of Public Health in May. But at age 23 we have data, and now we're beginning to actually see higher rates of college completion by age 23 in experimental communities that did these preventive interventions for substance abuse and violence prevention. Now you're starting to see differences in educational outcomes in terms of the proportion of people who graduate from college, which turns out to be obviously a big economic contributor both to the individual as well as to the community, as well as to taxes, et cetera. So I really think that including health economics in this from the get-go is essential for sustainability of whatever the initiative is, assuming that it, as Tom says, will predict positive outcomes.
Thank you, David. Okay, I'm going to go over here to Mike, and then I'll pick up a couple of comments here, and then we'll need to move on to the next panel.
Real quick thing, I just wanted to mention, Chris Scott's done a couple of articles looking at transitions, addiction as a chronic condition in which people are moving from using in the community to being in recovery, treatment, incarceration. We're talking about complex systems, possibly finding them in each of those places. Even if you do an experiment, modeling can help you do those transitions and accelerate. Rather than follow them for 20 years, you can, by capturing people at different stages of addiction, different points in the system, you can model that more efficiently and do a better job of planning the study if the data is available and extending it as though you had done a longer study. And that can get at some of the recovery support issues you were raising that otherwise would often take a lot longer to study.
I'm going to let our colleague from CMS speak before I move on to this side of the table. David?
Great, thanks. Yeah, I was going to add on, I think we even have sometimes a same pocket problem too. I mean, think about it from the payer perspective. We've thought a lot about, even within our own system, within a payer system, is there a business case to be made for increasing access to medication-assisted treatment? And I think we saw in Virginia, they did increase reimbursement. They saw almost a 50% increase in people receiving treatment and almost a 40% decrease in ER use. So I think, that showed some really, the power of bringing the payer to the table. And I I think it's also, if we can build that, evidence-based narrative that there is a business case for it, which we've anecdotally heard from commercial payers as well, and that will bring more of the commercial payers to the table. And I think really ideally you'd have, the federal payers and the commercial payers, and we only have, depending on the program, we have some limitations on what we can even do on the federal side, but to the extent that we can make it attractive for commercial payers as well, so you can have some consistency across the payment system, I think that's really important. So I think that this type of thing could really help, bring that type of conversation in.
Okay, thank you. Hendricks?
Good. I just wanted to say, I just think David's and Bruce's presentation here was great. I think this, I've seen and talked with you guys a number of times and other things. I think we're at a major transition period in here. And the HIV example, which you guys have been working on for many years in here, is a good one. So I would consider that departments of public health are data-driven systems. They really do really carefully look at epidemiology. But we can't get to the point of doing, how do we integrate science into them as well as we need to? I think the next phase in here is really what you guys are doing in here, and that is moving to a model-driven system. And then I think people are open to this one. I think it's a possibility of trying to use this one because the gap between what we know in research by rigorous randomized trials and all of the work we're doing and what people need on the ground is so big. We need to fill that place in here, and the models, I think, are that way. So David Hawkins talked about this is really a great opportunity for sustainment. I think it's also a great opportunity for visualization as well. And I was struck by the example that you had of tracking back the Scott County example over time in here. But people need to know whether or not these things are going to work in my community, in my system in here. So it's really adoption, I think, is that major decision making, and the visualization tools that you guys have been exploring in here, I think could be really very useful as well.
Great. Todd?
Just a couple comments. I mean, first of all, in some of the initial research we've done on sustainability, the ability to show the economic case or the business case has certainly supported that. So I'd echo that. And then also, I just want to cherry pick one item from their presentation that I think should be called out as we're thinking about the proposal, is the whole notion of scale up. And I think to have that in there somehow, even if it's just for the applicants to describe how they envision being able to scale up the intervention, I think would be helpful for those who follow.
Thank you. Sharon?
I have two comments that may be unrelated. And so in the program that you shared with us around overdose, I was struck by the fact that one of the things that you included was the value of life, but I wondered if that was actually the flip side of the cost of death or not. And how do you model that? Because in communities where, the people who are dying largely are young, often have young children, are leaving them behind with no care, then they're going to be on Social Security and disability for their life until they're an adult, and then their opportunities for education are poor, and many end up in the foster care system as well, which is also costly. And so I'm just wondering how that is valued as opposed to putting in a number that's a value of a life.
So there's a lot of literature and debate about how to value life, and I'm not going to belabor that point here because that would be a whole economics lecture. But it is at the individual level, but it's the value of those years of life lost going forward. So there's a value put, and there are various ways to put value on those years of life and whether those years of life are in better health or worse health. So that's the general approach. It is generally viewed as an individual, on the individual basis of the individual life saved. However, obviously, as you talked about, there's these family effects and community effects. And we're starting to explore that in our quality of life research, looking at the effect on spouses. But as you pointed out, the effect on children is also tremendous. The field is less advanced about that, but I do think that looking at outcomes related to what we call child and family services, different states I think have different names for it, but kids who end up in the system rather than being with their parents, looking at the economic impact of that is something that we can do in this context for interventions that are targeting that issue.
Okay, thank you. My second comment is actually about thinking about the utility of modeling, which I think has really great promise and makes me excited, and thinking that maybe there should be modeling done before anything is implemented, even though I realize that we have a very tight timeline. And part of that is because working within the treatment delivery system, what we know is that there are a lot of barriers to care that actually are preventing us from being able to provide access and care. So, and having critical partners like CMS. So just the example that Sarah gave where, maybe you can bundle a payment and make it more reinforcing for the providers. In the state of Kentucky, people cannot hang out a shingle without taking cash, because most people are on Medicaid, and if they accept Medicaid, then they are not making enough money to keep the lights on generally. So that type of thing. And then another thing I would ask for our colleague that's here is that the barriers for pre-authorization are really an issue, and those are handled on kind of a state by state and CMO by CMO, and I don't know whether or not there's any ability at a federal level to kind of just change that and mandate that let's get rid of pre-authorizations. People need treatment, let's provide it to them. And state level, yeah, but I know New Mexico did. I'm not clear that Kentucky's going to do that. We're doing it, kind of working with each individual agency, but it would be great if there was a more centralized way to show the benefit of that. And there are a number of other barriers that are similar to this that are very challenging to try and confront head-on, as a single person or as a single academic site. And I wonder, whether or not you could use modeling to show how that could change the outcomes.
Well, I think, again, back to Tom's point about the governors being involved. So one of the design questions that we should think about, or maybe after this meeting, is to what degree states are going to be required to have certain enabling legislation or enabling regulations, thank you, such that some of those barriers do not exist, otherwise they can't participate. Because if we find that those barriers are so important in order to get any result, then maybe that has to be a prerequisite. And whereas I don't think we can, build a model of all huge things, but I think that might be something that we could address in modeling in terms of trying to figure out from the literature and some back-of-the-envelope modeling what the impact of some of those barriers would be to support a requirement for some of those barriers to be taken away.